learned something new today. Make sure you buy the accent on the ticket or you buy it twice. There's 2 tickets. One that ends too early, and one that ends just at the right time, which I paid more than I should have for.
The Obama administration has failed to meet their backup deadline to get their website running, healthcare.gov. It's a lot of fun for us to, laugh at them and say we told you so. And we've been warning about this for 4 years about how bad this is going to be. And it's a good thing that the American public is getting such a bad first impression. But a faulty website can and eventually will be fixed, but the faulty policy underlying Obamacare can't be fixed. And to talk a little bit more about that, specifically what's going to happen to the old and the young under Obamacare, and whether it was really about health care to begin with, we have Josh from the Pioneer Institute, who's the Director of Healthcare Policy, and he's going to tell us all about the bad things that we're already starting to see.
Well, what a pleasure to be with you all tonight. My wife would consider this a public service that you're all here to hear about healthcare. She is sick and tired of hearing about it, so I appreciate that. So it's day 63. How do you all feel? Feel different? No, not yet. And certainly, 63 days have been almost every single day in the news something about the Affordable Care Act or Obamacare. Whether it's the policy itself or the website, there have been even more problems than I think anybody that studies this every day, somebody like myself, would ever have expected. When you spend over $600 million or close to $1 billion when you put in salaries on a website that can't even enroll individuals, we've got bigger problems here. Funny enough, and we'll talk a little bit about this, the Massachusetts Connector, the state exchange here, hired the same contractor that the federal government used, CGI. So we have run into some of our own website problems that I'll touch on. But I thought what would be helpful is just talk for a few minutes about what does the ACA or Obamacare mean for Massachusetts, for different populations, break that down a little bit, and then we can stop and have any Q&A that you'd have. I could talk from 9 to 6 if so allowed, but I just want to kind of lay the framework for what's out there for people to be aware of and how to talk to their neighbors about it going forward, specifically what's happening here in Massachusetts, largely because we've been told by our elected officials for the last 3 or 4 years, they're the same law, don't worry about it. That has not played out in reality. There's actually quite a few differences, so we'll talk about some of those. But just to start, I think it's really important to realize that our healthcare system is not monolithic. There's actually kind of 6 healthcare systems. And the federal law will impact each of those 6 different groups in varying ways at different times. And I won't go into all of those, but perhaps you can think about where you fit in those 6 buckets or where people you know fit in them. So the vast majority of people get their insurance from their employers. There are 2 different kinds of employer setups, ones that are bigger, they call them self-insured. Those are regulated by the federal government. If you work at a self-insured company, that's the other one. It means usually you're a little bit smaller and you work with one of our local insurers. They hold the risk for you because your company doesn't hold the risk. You could also buy insurance on your own in the private marketplace. That's where we've seen most of the cancellations happening nationally, is in that smaller section of the individual market. What's unique about Massachusetts is the small business and the individual marketplace in Massachusetts are the same. They merged them as part of Romney Care. And that will be a lingering issue here in our state to deal with over the next few years. It was an option under Obamacare, and no other state has taken that option to merge the 2 markets. And there's a variety of reasons why that I'm happy to talk about later, but just want to mention now. The other areas are if you're over 65, perhaps you're on Medicare. Medicaid is for typically lower income or disabled populations. That's kind of 2 more of those buckets that we traditionally think of. Then there's those that will be on the exchanges. In our state, we have a state-based exchange. It's called the Connector. We'll be talking a little bit about them tonight. And then finally is the uninsured. Those are remaining individuals that don't have insurance either by choice or life circumstance or whatever. Maybe they're here illegally and they don't have employer-based insurance, so they remain uninsured. So let's talk a little bit about what Obamacare actually means for Massachusetts. Because as I said, you listen to the governor all the way down, they have said, nothing to see here, don't worry, this will only be beneficial for Massachusetts. There won't be any downsides. We've already tried this. People have already, almost all of us have coverage. Don't worry about the cost, even though they've passed a major healthcare bill every 2 years since 2006 to try to deal with some of the costs. Don't worry, this is all going to mean very good things for us. And my takeaway largely, in one sentence, is the only benefit to Massachusetts for the Affordable Care Act is more federal dollars. So if I'm a state budget writer, I'm pretty happy about this. If I'm a taxpayer, I'm livid, because I pay both federal and state taxes, and as a result, any free federal dollar is not actually free. We have to pay for it, kids have to pay for it going forward, we have to borrow it, given that we have a $17 trillion debt. I think we're all pretty aware of this issue going forward, but that's what you hear state officials talk about. This is great for us because we're going to get more federal dollars into the Commonwealth. But it kind of ends there, unfortunately, for the benefits for the state. Just a couple nuts and bolts before we get into actual provisions. Differences contrasting the 2 laws. In Massachusetts, in 2006, we required employers that had 11 full-time equivalents and up to offer insurance. Under the federal law, it'll be 50 and up. It's a big change. The penalty on employers that don't offer insurance also changes. It goes from $295 a person to $2,000 or $3,000, depending on the circumstances at a small company. The individual penalty for not having insurance is different in the 2 laws. So ours is currently structured as a very confusing formula. It's a percentage of one of the lower cost plans on the connector. Translates into a few $100s or so. Under the federal law, it's $95 or 1% of your income, whatever is less. But we can thank our state leaders. They said you're going to pay that and anything that's over and above that's owed to the state if you don't have insurance. So we're a little unique again. They've layered the state penalty on top of the federal penalty if you don't have insurance going forward. So let's talk about what is actually going to happen in the marketplace. And we'll start with the connector, because this is one of the 3 stool legs, if you will, that's part of Obamacare. It's the exchanges, Medicaid expansion, and the tax credits that are kind of part of that. That's their 3 ways to try to get increased coverage. And when it comes to our exchange, again, we have a state-based exchange. It's run here in the state. It's been running since 2007. What's going to happen there is 100,000 people are going to be taken off of that and put into Medicaid. So we will have 25% of our state population, when it's all said and done, on the government-run Medicaid program. which has some serious dysfunction in my opinion. We'll talk about that. 25%. 30% of the population in Boston is currently on Medicaid, so that will go up a few percentage points. We have over a third of the population in downtown. Yep.
And that's just Medicaid, not Medicare.
Just Medicaid, correct. So again, the program for typically low-income and disabled folks. And one really new thing under the federal law is we're expanding coverage to a population that we've never covered before in any meaningful way. It's for individuals that don't have children and don't have a disability. Again, people that are able-bodied, that can work, we're now giving them free, largely free, health care for the first time. In a lot of states, and Massachusetts is a little bit more generous on this, these individuals don't qualify for any other social services. But we're going to give them almost free health care. And in a lot of states, those individuals have private coverage now. So we are going to transfer them from buying insurance on their own or their employer offering it to them onto a public program. So we're paying...
On the basis of income?
I'm sorry?
On the basis of income?
Based solely on their income. Yep. So we're going to transfer those folks onto the program. And that program historically has been for the disabled, pregnant women, and children. What most people would think of as a true safety net. And now all of a sudden, as part of the expansion, we're going to put in this able-bodied population. And any dysfunction that we have in that, which access is a huge issue, if you live on the Cape, 14% of primary care doctors are taking new Medicaid patients. 14%. And that's horrific if you're on the program. And now we're going to add 100,000 people more into this program. So that's what's happening at the connector. If we thought there was any value to the connector, we're throwing it to the wind because Obamacare is going to move 100,000 people out of it.
Question.
Yep.
If someone went to that Medicaid program, could they buy private insurance? Could they buy?
Repeat the question because we can't hear it back here.
If the question is if you go onto the Medicaid program, can you purchase private insurance? There's one very, very small slice of the program, it's kind of almost a pilot program, where they will, if you have a certain kind of offer of employer-based insurance, the state will pay for a portion of that private insurance. But largely no. The answer is once you're put into the program, you really can't do anything but be in the program. I mean, you could not enroll, I guess, but most people want some sort of coverage if they can get it. The unfortunate thing for me is if it's critical as I have been of the connector over the years, and we can talk about some of the dysfunction, they actually offer people some choice. If a beneficiary doesn't like their plan, they can vote with their feet and pick another plan. Once you're in Medicaid, it's what the state gives you. You don't like it, too bad. You can't find a doctor, too bad. You're stuck. So I do think that there is a real disservice for individuals, in my opinion, if you don't really have a choice and you're put onto that program.
Are they going to consider assets or risk income?
So there's a whole different way they're going to assess your net value. It's called MAGI, modified gross income. It's very complicated. I have read the definition probably 20 times, and I could give you a general sense for what it means. But I guess your question is, are they counting assets? They count certain assets, but not all of them. In fact, the federal government over the years has incentivized states to not look at all assets to increase enrollment in the program. So that doesn't go away and change, but they are changing the way that we calculate eligibility. The other big kind of takeaway at the connector is that they are expanding the eligibility under the federal law for who can get insurance. So if you make between 200%, currently it goes up to 300% of the federal poverty level, and for an individual that'd be just over about $30,000 for them to be eligible. If you now make between 300 and 400%, so roughly about $40,000, you now are eligible for a government subsidy as part of that program. So they're expecting about 80,000 more people. Most of them have private insurance currently, but we're going to change them on to a government subsidy program here in the connector. And then they're requiring all 150,000 people that are currently on the program to re-enroll. So as you watch the news in Massachusetts, by March 31st, they need 230,000 people to enroll for them to be, in their opinion, feasible. You know what the total was after the first month? 1,000. So they are very far off where they need to be from an enrollment perspective. I calculated a couple weeks ago. Basically, they needed 2,000 people every day to enroll for them to hit their mark before March 31st. They've had huge website problems. They largely denied it. Rob has been part of the effort to put a little flame under their feet. To try to get to the bottom of it. The website has not allowed people to enroll as easily, just like the federal website. They've run into some big technical problems, and that's part of the reason that only 1,000 people have signed up. But they've only had 25,000 people actually submit an application, so they're still really far behind where they need to be. So that's one thing to be watching for in news articles going forward. They spent $69 million on a new website. It doesn't work. They're spending, I think, $7 to $10 million to try to fix it going forward, and they've received $180 million so far to change over to an Obamacare compliant exchange.
The Carl said a week ago, and they hired a consultant to tell them this, it's more screwed up than the federal one. It's in worse shape.
From a security standpoint, my understanding is that the code is in worse shape than the federal one. So they've got some work ahead of themselves to get it in order. They will, again, they'll get it in order. They're spending enough money. So, yeah, Rob.
The connector documents themselves say that the connector got $180 million, but the state got $260.
Mm-hmm.
The general fund got an extra $80 million to spend on the one. That's not part of the connector.
Yeah. So a lot of federal dollars coming into the state. I think as taxpayers, we want to start to know, are we actually getting any bang for our buck? If people can't even sign up, then I think there's a fair argument to be made that we're not. As far as cancellations are concerned in the state, you'll start to see some of them. Perhaps you've received notification yet?
John, so that number, the 230,000
Yep.
that you do enroll, are those the new enrollees that aren't in the mass plan currently? Or
It's
is
a
that
combination.
completely new?
150,000 that are currently on the exchange that need to re-enroll, and 80,000 that are now newly eligible for the program. It's a combination of this.
And the 1,000 have enrolled so far.
1,000 have picked a plan, which doesn't mean they've finished. That you have to pay before you're technically enrolled. So yeah, they've been deemed eligible. They've put in an application, it's been accepted. They've been verified. They've selected a plan, but they haven't paid the first month yet.
And is everyone that's in the mass plan, will they just basically jumped over to Obamacare, or is that?
They have to select in. They have to re-enroll.
If they don't? If they don't realize they have to do that?
That's a concern. That they'll find themselves uncovered come January 1st or March or April of next year. Yeah, so they have to play an active role in reselecting back in or applying. So, and if they don't, then yeah, you'll find probably a lot of unhappy people.
I don't know if this is relevant to, or maybe I should look for this question later. I'm just giving you an example. My wife is seriously disabled, and therefore she has always been on the Mass Health, which is the Massachusetts Medicaid.
Yep.
And I must say, she generally, but of course we live 2 miles from Harvard Medical School. I think this has some effect on the kind of care we get. We're very close to all the medical facilities in Boston, so she's generally had good care. And has an important doctor who's a professor at Harvard Med School from Beth Israel. But she was advised that they were going to throw her off or they were going to do something. So she, in fact, signed up for her employer's, which is Harvard Pilgrim, and it's expensive. But they assured her that Mass Health would subsidize the premium.
Some of it, yes.
So it's very confusing. I dealt with Commonwealth Care, and they were capable of sending me, they're capable of throwing me off my plan and it's simultaneously sending me a letter admitting me into it on the same day. So.
Yeah, that thing happened to me.
Really?
I
Yeah.
don't know if they're- yeah.
And they have, in the old days, this is before Obamacare, when you had to appeal to them, they had something called the Exemptions Department. It has no phone number, no physical address, just a PO. So you cannot query them. You have to wait for the decision to come on high in an envelope.
Yeah. Yeah. Well, hopefully they'll maybe be a little bit more consumer-oriented going forward. I don't know. They're required to have an appeal process, so maybe it'll be a little bit more accessible. But I do think that, I mean, this raises a very good point, which is Medicaid, again, just to return to this issue for 1 second, traditionally has been a program that we want to support the people who are on the program that need it. But now we're adding a new population to stretch the system. And in Massachusetts, we are relatively generous in how much we reimburse doctors In other states, they're not. And from an access issue, there was a story in the New York Times today about California, where they just have doctors saying, I cannot afford to take another Medicaid patient, period. I'm already losing money on every single patient for Medicaid. So there's a moral argument here going to be played out. And because we're generous in Massachusetts, over 40% of the state budget is healthcare related. And the vast majority of that is Medicaid.
That's what, it's gone from 25 to 40 since '07, right?
In a few years.
So everything, all else being equal, no Obamacare. Obamacare was going to eat the entire state budget in about 10 years.
Well, we're moving in that direction. I mean, our state leaders have made a very conscious choice, both in 2006 and onward, to spend the vast majority of our resources, discretionary resources in the state, on healthcare. And that has come at the expense of education, public safety, public health, whatever, higher ed, whatever other issues voters may care about. That money has gone to healthcare. And just one brief anecdote, the whole debate that we just saw about raising taxes for transportation in Massachusetts was really about healthcare. They didn't have any money for transportation because healthcare was eating it all up. And so this is an issue that I think voters need to be really aware of and start to ask questions. And most legislators know about healthcare. They have simply just gone along with, oh, we're the first in the nation doing innovative things. Great, yes. So I think we need to ask a little bit more critical questions of them going forward. And I suspect it will happen starting next year, because cancellations in our state will start to happen. I went through the filings for the Division of Insurance and counted about 352 plans that will be canceled. I don't know if anybody's had theirs canceled yet in the state, but it is coming, and in Massachusetts it will be on a rolling basis. And it will start with some small business groups and in the individual market. So they will say, you can no longer get this plan, here's one that's kind of similar, oh, the premium's slightly higher. Now, it won't be as drastic as we've seen across the whole country, because our market's really heavily regulated to begin with. We've had a lot of the Obamacare regulations for years, for decades actually. So we've been paying more for health insurance for years than other people have because of that. So I wouldn't anticipate the spikes will be quite as drastic going forward. The connector, just briefly, to return to them from a financial standpoint, is choosing to spend $120 million extra of state money to wrap coverage for people on the connector, so it looks more similar to what we currently have now. And very interestingly, when they looked at the current plans, the federal law has these metallic tiers, how generous the plans are, and almost all of them were platinum plans. Almost all of our plans qualified as platinum, very, very generous plans with big benefits. And the connector has decided, the analogy I use here is they've decided to keep offering Cadillac plans instead of offering a Honda plan, which they could have, or a little bit more affordable. They've decided to spend $120 million of taxpayer money to wrap that around going forward. Just one brief last note on the connector. Politics has, maybe not surprisingly, played a role in the Obamacare rollout in Massachusetts. The state has been granted 2 grace periods, which seem to lack a legal rationale from HHS, but have pushed back some of the major changes in the state a couple years. I'll talk about one of them in a second. And I remember I went to one of the connector board meetings for their group, and they discussed, this was in 2010, and they discussed, we have to get this right because it's President Obama's legacy that we have to protect. So there's some deep, it's a deep political issue when it comes to implementation. It's not necessarily about keeping the state's ability to control what's going on. There have been big privacy concerns in the state. When the state passed a law to bring us into compliance, they put in this really overarching provision, and I'll read it for you. It says that the state is allowed to share your enrollment information with the Department of Revenue, these are all state, HHS, Department of Public Health, the Executive Office of Labor and Workforce Development, the RMV, the Department of Corrections, the Center for Health Information and Analysis, which is a data agency, and any other state agency, department, division, commission, authorities, or political subdivisions it deems appropriate. So any information that you're giving could, in theory, go to these other state agencies, and it will be shared with the federal
Perhaps
government.
John Walsh's tickler file?
Perhaps. They also, if anybody works for a small business, they've also, they killed off the buy-in co-ops that some small businesses were really excited about. And they got rid of some of the small business rate increase buffers that we had on the books before. All right, two last things. Let's talk about taxes, new taxes under the federal law, and something called rating factors, which I apologize in advance. It's a little bit wonkish, but it really is important if you work at a small business, so I wanted to talk about it briefly. As far as new taxes are concerned, the state will be hit disproportionately hard because we tend to have higher incomes. So that's the first thing to remember. We'll pay more of the taxes than most other states. At Pioneer, we've done a series of reports just on a couple of the provisions, and our estimates, about $4 billion in new insurance taxes over the next 10 years, $14 billion in Medicare cuts for hospitals in the state. There's a very small 0.9% payroll tax for Medicare that will translate into about $2 billion in new taxes for Massachusetts residents. And that's a smaller of the two. There's also a 3.8% tax on unearned income, which is the first in our nation's history. If you have rental property, you're selling, you have dividends, you're selling stocks, you will pay a 3.8% tax on that above a certain income threshold. Another really big one for our industry mix is the medical device tax. We did an estimate there for the 19 largest companies, and it was $4.2 billion over the next 10 years that will come out of the medical device industry, Massachusetts down to DC. And this is actually a bigger deal, not for the big companies, although
This is in Massachusetts.
in Massachusetts. They'll say we're concerned about this, but it's really a bigger deal for the smaller companies. A company that just got its first approval for its first device, the tax is levied on sales, it's not on profits.
It's on gross revenue, so you could not turn a profit and still have to
You
pay
still
the
have to pay
tax.
the tax. So this is a bigger concern for R&D, for these companies to survive long term. It's going to take them much longer to actually earn back what they invested. Yep.
What was the rationale offered for this tax in the first place? Does it make any sense? Or?
The rationale I've heard is everybody had to pay a little bit to get the end goal. That's what I've heard.
Okay. So,
You can decide whether that's
Okay.
a reasonable rationale or not.
Okay.
But it was every industry has to pay. This is one way for us to go after the medical device for them.
where the money is.
Well, there is some money there, yeah, certainly. I mean, if you get multiple devices that work, we've got some great big companies. I mean, it's Massachusetts, Minnesota, and California are the three major hubs for medical device, and maybe not unsurprisingly, you see bipartisan support to repeal this. Because I think people realize it actually will have a pretty big impact on those smaller companies at least. And you may see a political compromise and they may say it still is applied to the big companies but not the small ones, or it's only on profits or something like that.
It was not repealed in the negotiations of shutting down government. I thought it was the one
No.
thing that.
People thought it was going to be included and it was not.
That's what I was going to say, there's bipartisan support
Yeah, for it.
to make that happen.
Yeah. So we may see something. And just on a side note, I mean, there have been about 20 legislative changes to Obamacare.
Legislative or fiat?
Legislative. And then a number of administrative actions. So while we don't ever hear about this, Congress is tinkering in the law on a relatively regular basis, changing different provisions going forward. And the big one that maybe of note is the tax credits in the exchanges. They increased how much people have to pay back if their income changes. They misestimate their income. They have to pay the IRS money. So, all right. And then the last one that should be on your radar if you have insurance in Massachusetts, I assume most of us do, is the Cadillac tax. This is for generous health insurance plans that will go into effect in 2018. And we ran some basic numbers at Pioneer and found out that at least half of people in our state will be subject to this tax. Now, just to briefly explain how it works, there's a threshold for individuals and family policies. And if your plan is over that threshold, you pay a 40% tax on the difference. And a vast majority of people are either right near that threshold already or already over it. So if you're a public school teacher, a cop, a municipal worker, a lot of private health insurance companies, all will be subject to this tax. And we're talking, tens of thousands of dollars year after year of potential tax if we don't get healthcare costs under control at some level. So just raise that as something that you should be asking your HR department about, or trying to figure out how people are going to adjust. They may cost shift onto you to try to get the cost down. You just need to be aware of it going forward, because it will have a really big impact in the Northeast, specifically in Massachusetts, because we have the highest premiums in the nation, actually in the world, but highest premiums in the world. All right, the last one that I'll just briefly mention that I think might be of interest is this rating factor change. And I'll step back for one moment just to explain how insurance is written. The insurance company set a base rate that they file with the state, and they say this is how much we're going to charge for this policy, and then based on a number of characteristics, they then adjust the policy. The kind of industry you work in is an adjustment, how many people participate in a wellness program is an adjustment, where you live in the state is an adjustment, your age is an adjustment. Well, Obamacare said Massachusetts has 11 of these factors. We're only going to allow 4. And this is a very interesting political history, which was the federal government wrote regulations, the state ran a report, hired a consultant, ran a report, realized this was going to disproportionately affect small business, wrote a letter to the Fed saying we need a waiver because of extreme premium increases. That was their language in the letter. They were denied an outright waiver, but granted this weird 3-year grace period, which they slowly get rid of the factors going forward. Now, why does this matter? It matters because for the first time, the federal government is telling the state how to regulate its insurance markets for individual and small businesses. And even though the political elected officials want a waiver, and small business has been begging our delegation to seek a waiver, the federal government has said, no go. We will tell you how you have to regulate your markets. And I think this should be a concern not only for state officials, but also for people who value some sort of local control and feel like Massachusetts is not Arizona, Alabama, Mississippi, you name any other state. I mean, there are unique characteristics to a state like Massachusetts that I think should allow for a different regulatory regime and for us to be able to change it to reflect different market dynamics that we've lost. We've lost that ability under the law. And so I do think that there's an opportunity to articulate an alternative vision going forward. We're giving these books out free, so I'm going to pitch it. We wrote a book that we released last year called The Great Experiment, and we released it before the Supreme Court case as our way of trying to articulate a new vision of state and federal partnerships on healthcare. So if you really can't sleep at night, you can feel free to get in contact with Pioneer and ask for us to send you a book. We'll send you a copy or two so you can read through it or give it to a friend. But I think we need to get serious about some alternative visions to address these concerns instead of just complaining about them, as I just did a laundry list of some of the concerns. But yes, ma'am.
In terms of the logic of state-to-state variation, one thing that I know is that Massachusetts does not allow for the corner clinics in Walmart and so that are allowed in other states. And a friend in Colorado went to one on a weekend for an emergency situation. She said the bill was $83 for the visit.
Yep.
She's Medicare, so they're going to pay for it. But, is there, I'm so suspicious that there's, some kind of a lobby that's against that in Massachusetts.
Yeah, the doctors.
Are you saying that, that's something that will be done away with?
No, I'm not saying that. I
That difference
apologize
will
if
be
there was
done away
confusion.
with.
No. In fact, we're going to have to go there out of necessity, I think, because the bill was largely about getting people insurance cards. It wasn't about actually dealing with the care and trying to decrease costs. Now, there's some pilot programs that deal with costs we can talk about, but there's some slow movement in the direction that you're mentioning in the state. We've been pushing on this issue for a couple of years. They are now allowed to be open limited service clinics, is what they call them. CVS is the only company that has them, and they ring the city because Mayor Menino was opposed to them. So there may be an opportunity here in the city with a new leader coming in to open those. We've been pushing on some of the regulations that have made them more restrictive. We're pretty far behind other states, like in Florida. You can fly into Orlando Airport and find a service clinic there, get flu shot, physical, it's all posted price-wise. We're not quite there, and I think it's because we have such a big medical complex in the state that we need to kind of shake up a
Especially
little bit.
Boston.
Especially in Boston, just to kind of, we need a little bit of disruption there, to put a little bit of pressure for them to react and lower their prices because there's a little bit of competition. There has not been a lot of competition going forward. So that shouldn't go away. In fact, I think we'll be revisiting that issue shortly. So, yeah, Brian.
I, like a lot of us here, are somewhat cynical about the federal government. And there may be others who also believe that this is really all about control and not care. But you made an interesting point earlier about the income levels. And it's my idea that Democrats have realized that they have eliminated income taxes for a huge percentage of the population. And we use our tax code to control people. You know, buy this kind of car and we'll give you a tax credit. Buy a house, we'll give you this deduction, et cetera, et cetera. If you only make 200% of the poverty level, we give you your phone, we give you your health care, et cetera, et cetera. And I think the Democrats have realized that there is this gap of millions of people that the federal government can't control either through the tax code because they're high income or through benefits because they're low income, and that they're using Obamacare to fill that gap. So we're talking about more middle class entitlements, middle class benefits. And I'm just wondering if in any of your research you've seen that or noticed that these benefits are moving farther and farther up the income scale.
Well, I'll leave the politics to you, but yeah, I mean, there is a sense that we have the large structural issues we have in DC from a budget standpoint are healthcare related. They're Medicare and Medicaid, and this adds a third entitlement of the tax credits that we have to be concerned about from a financial standpoint, and certainly adds more people to have a buy-in to resist change in the future. So I think there's some truth to that. I think what's interesting is that there's a little bit of hand waving going on here. There is redistribution that young people have to pay a lot more for health insurance so that older people pay less. And that's even more acute here in Massachusetts because we're more restrictive. We have heavier regulations so that young people pay even more than they do across the whole country. So there's that kind of generational redistribution, and I would call it theft, quite honest, for younger people, because they will pay, there's been some good work on this out of Duke, saying that young people will pay a 13% effective tax on all medical care due to this having to pay more early, even though they get older. The second one is that there's a little hand waving around the Medicare program, and we saw this during the election. It was very heated. That $716 billion fight back and forth between Paul Ryan and the president and his team. I mean, the way they're funding the tax credits and the Medicaid expansion is taking all that money out of Medicare. And Medicare's own actuary said those cuts will not stand because access will be so bad for seniors. So that will go away, I think. Politically, there'll be too much heat, and now we add even more to our national debt. So, I mean, you see there's this like real funny behind the scenes moving around of money.
Okay, well, let me ask you just a very quick question on that. I just learned that for 2 years they doubled or tripled the Medicaid reimbursement rate in order to induce more doctors to take Medicaid.
Yeah.
What are since we've been trying to do the quote-unquote doctor fix for 20 years, what's the chance that those higher reimbursement rates out of Medicaid are actually going to end at the end of 2014?
Well, they're scheduled to go into effect, so, I mean, you know as best as I do whether they'll go back and change something on that. I mean, the hospitals will complain. They'll say they're in poverty and they need those money, and in some states, they're justified. I mean, in New York, they pay, the last data I saw, they pay about 30 cents on the dollar for a Medicaid patient currently. If I was a doctor, I would simply refuse to take Medicaid patients. And 30 cents on the dollar, that means you have to cost shift under
You
those
might,
people
you
with
might as well
private
volunteer
insurance.
at a free clinic in your spare time.
That's
and
right.
charge real-
If you want to do a social good, it's
real
easier
money,
for you to spend a
pay
weekend,
patients.
a month or something volunteering. Absolutely. I mean, That's probably what I would do. Or see them for free and not even deal with the Medicaid program. I mean, that's almost easier for you. So you don't have to deal with the paperwork and the state bureaucracy and whether they actually pay you on time. Just see them. So I do think in our state, I think the question reimbursement levels is not really the issue for most doctors participating. It's the dysfunction of the program. It's the added paperwork. So I think it'll play out a little bit different here in our state. We also have massive payments that go to a few safety net hospitals in the Boston area that they've negotiated over the years to get extra money because they claim that they can't keep up with the big hospitals. And I should mention that the 2012 law, it's called Chapter 224 if you follow it, but there's this big law that they passed in July of last year and they called it Health Reform 2.0, even though it was the fourth healthcare bill that they passed. But the law put a cap on growth. They took money from rich hospitals to give it to poor hospitals to try to make it equal, but of course that doesn't solve the problem long term if you're not paying the hospitals enough. Anyways, so not only do we have Obamacare playing out in Massachusetts, we have this massive new reorganization due to state law, and all the hospitals are consolidating as a result of it. So you will pretty soon be in something called an accountable care organization. It looks a lot like an HMO. And you better know who's in network and who's out of network, because if you go out of network, you may be financially liable for a good percentage of the cost. So there are big changes happening. When you talk to state officials, they say these are two once-in-a-lifetime events happening at the same time. And they're trying to juggle it all, which of course they're unable to. And for those of us trying to keep track of 20,000 pages of federal regulations, I mean, it's impossible to keep it up. So that was a long answer to your question, but yeah.
Well, I have a few, which are, the questions are short, their answers may be long. So 40% of our state budget is now all healthcare related. Where's that going to go? Does the Obamacare put that into overdrive? Does it really not have that effect on the whole overall cost of care? I mean, will healthcare continue to eat up the budget? Is it going to be 50% in 5 years?
Yes, if to be fair, supporters of this new law in Massachusetts would say, the cost containment law would say, that's why we passed that law, that will have the intended effect.
That was just a big bureaucratic fix.
Well,
okay? It's red
that is
tape
true.
and everything else.
That's true. So
Rob had something on that last year too.
yeah. So if that doesn't work, then yes, we're going to keep going up. And I think as a result, they've got two choices. They either have to raise taxes again, or they have to cut somewhere. And maybe eventually a new administration would do something along those lines. The current administration has shown no willingness to do this. In fact, as I pointed out before, they're opting into spending more, $120 million every single year as an optional expense. So I anticipate it will continue to go up.
Next question, when do the IPABs kick in?
The IPAB?
Yeah.
Well, nobody's appointed to IPAB right now, so...
Yeah, but I mean, this sort of this desperate cost containment, which is what leads to the concept of death penalties. Okay, they'll wait until it's bankrupting absolutely everybody, and then they'll say, at that point, they'll set up a board and say, we just can't care for these people anymore.
I'm not sure I have any deep answer to
Okay.
answer to that question. I mean, we'll just have to wait. I think politically, that will have to play out first.
And a third question, which is just a sidelight, which is, do you know anything about a program called dual eligibility?
Yeah, let's talk about it afterwards.
Okay, never mind. It's a minor thing, or it's a
Yeah,
sidelight.
no, that's part of Obamacare. I'm happy to talk about it afterwards. So, yes, sir.
Are they going to be increasing restrictions on doctors'
What do you mean by that? Are they going to be reducing doctors' payments?
Exactly.
Well, the $760 million out of Medicare is largely taken out of doctors' reimbursements for Part A, which is hospitalization and hospice care and nursing homes, and Part B, which is the private Medicare Advantage program. So yes, I mean, they will be decreasing in the Medicare program the amount of money that goes to them. There's a big question now about the exchange plans. People are calling them Medicaid Plus because the reimbursement rates look a lot like Medicaid. So all of these individuals who are being added to the exchanges, it appears that they're going to pay very similar to Medicaid. So that, in a sense, if they're going from private insurance to an exchange plan, would be a reduction in their reimbursement rates going forward. Yeah, Rob.
Maybe the elephant in the room, you might not want to answer it. Do you think this is all part of a plan to go to single payer? That they wanted this to fail, that they designed it to fail? And that this is all a plan to say, see, this can't work, so we've got to go to single payer and that?
I noticed that in NRO, Andrew McCarthy has decided that's what's been going on all along.
I think for some of them, I mean, Barney Frank said as such when he was voting for it. So I think for some people, I think there's a lot of people now that didn't, to be quite honest, didn't cross their mind. They just felt like they needed to do something, and so they did this. I mean, Scott Brown, as you all know, kind of put a wrench in their plan. The bill that became law was a bill that was designed to get through the Senate. It was never designed to become the final law. They were going to fix it in conference committee, make it, work properly, but because of Scott Brown, they had to go with what they had. And so it was a kind of dysfunctional law that didn't quite make sense, hadn't been really thought through all the way. If you talk to the Democratic staffers, that's what they'd say. Well, we were just patching it together to make sure it got through the Senate. So now we're starting to see some of that dysfunction play out. So, yes?
I can give some partial information for Edward's question about the panels. I'm a biomedical researcher, and one of the things that's become overwhelming in funding, federal funding for research, is away from basic science and clinical trials, but what's called comparative effectiveness. And this is really where it's going to lead to. When they say that, analgesic therapy, versus surgery for osteoarthritis, there's no difference. They'll no longer do surgery. So the NIH is in cahoots with these guys to do this comparative effectiveness and to find rigorous data and, with unequivocal answers that are in the literature. It's going to be very, very difficult to do it. And so far what they've come up with is these comparative effectiveness studies, generally show that there's not enough information to show that one's more effective than the other. Therefore, we'll go to the low-cost one.
Yeah, I mean, this is, I like to think of it as academics running the show at the moment. And they've been given a chance at the wheel to try to come up with, and that's started in the ivory towers to say this is how we're going to solve the healthcare problem. We're going to compare different procedures and go with the one that's
Well,
lower
there's not
cost.
necessarily a malicious intent there.
Oh, no, and I agree. I agree. I mean,
the idea is we don't have enough information, the statistical tools don't show these differences.
Yes.
So that's a little bit different.
Well, I don't think there's again, this is, from my perspective, a very good example of good intentions that could end really poorly, right? Where the goal is to saying, we're spending too much on healthcare, a lot of it's wasted, let's try to make sure that we are getting good value for each of our dollars.
But on the other hand, the other thing that's coming into this is personalized medicine, saying the reason that the statistics and the epidemiology don't work is that you're including too many people in the trials, and you can't really find out what's more effective than another thing. So it's all a big mess, but it's going to be exploited in a very, very negative way, I'm afraid.
Well, share some of your concern. I do think you're exactly right. There's two opposing forces here that could have an interesting face-off at some point going forward. Yes, sir.
We know that parts of Obamacare are dysfunctional. Do you think the law is dysfunctional enough that it will collapse on its own weight?
I'm of the opinion that no, it won't. It could by state, but I don't think overall it will. Because there's enough kind of safety valves put in place where insurance companies get a little bit extra money to make up for some of the dysfunction. Largely what it comes down to for us to think through is, from an exchange standpoint, it depends on who signs up, who drops coverage, how many people end up getting these tax credits. If it's only older, sicker people, then there's a serious concern for what they call, affectionately call, a death spiral, which means that insurance premiums have to be adjusted up and up and up and up, and anybody that is not really, really sick gets out. That would happen state by state, and it would take a couple years to play out. So I guess you would call that a collapse, but I don't think it will happen across the whole country. I mean, I don't want to say that I wish it did, because then I think it would precipitate a quicker change to the law. But I think what will happen is there will be certain states where it is successful and enough people sign up that they're functional. Just like Massachusetts was kind of functional. It took a lot of federal money to get us there, but we were functional. And enough people with varying demographics sign up that it kind of worked from a risk pooling perspective. So the open question, though, is if you have a handful of states that fall apart and don't work, what happens politically? Do they bail out those states? Do they change the law, give them an out? I'm not entirely sure. Again, I'll leave that to the political folks.
And so which states are most vulnerable to that? Which states are most
Well,
close to the edge?
it's a little too early to tell because we've only had 2 months of enrollment. I mean, I think there's a handful of states that I would put on my radar: Alaska, Mississippi, Alabama, where enrollment numbers have been so dismally low that I think they run the risk of having troubles going forward.
I
getting
think,
up to time here?
yeah, we're going to have to wrap
Yeah,
up soon, but I think Patrick has a question.
Yeah, just a couple of observations, and I think this is a real big question. Over the last, I've worked in healthcare IT for a quarter century. The government has gotten more and more involved to the extent where I think it's really crippling the system. While during the healthcare debates between like 2009, 2012, the Wall Street Journal was reporting, okay, for every dollar that's spent in healthcare, it was going from 49, 50, 51 cents of every healthcare dollar is controlled by government at all different levels: federal, state, local, veterans, CHIP, etc. The federal government has been getting into the healthcare field at a humongous rate. I don't know if people are aware of it, but during the part of the ARA, American Reinvestment Recovery Act, there was $20 billion in there for healthcare IT, which is still rolling out over time. We're going to be entering stage 3 of that rollout at some point in the near future, God help me. My point being is that the government has got increasingly more and more involved, but yet people, for some crazy reason, think that the way to fix this is to have more government involvement. Why is there not an argument being made substantially that the problem is that government's gotten involved and is screwing up the system, as opposed, and we don't need more government, we need a free market, like in things like in LASIK surgery, what's the other? Cosmetic surgery. Prices get cheaper. Where there's a market and competition, it actually works. The problem is that the government has gotten so involved and screwed it up so much. I can't understand why people are saying, well, the solution is more government. A little, some cancer's bad. Let's have more cancer to really kill it.
Yeah, I mean, there's a long history here of the government getting more and more involved. I mean, I think the problem that we have is that we are not on the precipice of a functional market in healthcare. I mean, what do you need for a functional marketplace? Some sort of transparency about quality, about price, and availability, supply and demand. That's very hard to get your hands on in healthcare. So until you have, I view this much more incrementally and say, what are the tools that get you there? So whether it's a health savings account, whether it's a limited service clinic.
Which is now illegal. A health savings account is now illegal.
Well, they're not illegal. They're less generous than they were previously. But I think if you move in that direction, then you inject the change into the system. But I mean, you're absolutely right that there has been this belief, and this has been around since the 60s, that healthcare is it's different. It couldn't possibly respond to market incentives, but yet then people complain about pharmaceutical advertising and doctors being greedy and hospitals being greedy, when that's an economic argument. So I think that there needs to be a little bit of a frank discussion.
I specifically work on a pharmacy application. I can tell you that everything is geared towards what you can get reimbursed from Medicare, Medicaid, etc.
Yep.
You couldn't have a $70 aspirin, the proverbial $70 aspirin, if it wasn't being approved by, it's not the private insurance companies that are saying, yeah, let's pay $70 for an aspirin. It's saying, it's Medicare, Medicaid saying, this is what we will reimburse you for these medications.
Yeah.
And if you have a 300 hospital corporation, say, that can get drugs a lot cheaper, but yet they're being told by the federal government they can charge up here, you're going to go for the bigger price.
Yeah. I would just say one thing, and this is a good context for the Obamacare changes that are happening. We're basically buying a car every year in the form of health insurance, so we need to spend more time on it. I mean, you've got to talk to your HR department. If you're buying it individually, you have to go talk to a broker. Whatever you need to do, the only way you're going to get to a more functional marketplace is until we actually play some part in our health insurance and then in our health care as a result. We're really far from that. The federal government's partially responsible, state government employers are partially responsible. We are too. So we have to play a little bit more active.
Agreed. I mean, I'm from Bedford. I could go to Lady Clinic or Emerson Community Hospital.
Yeah.
One world class. My copay is $20.
Yeah.
Where am I going to go?
Yeah.
I'm going to get the world class treatment, or am I going to go to the
Sure.
place that's going to take care of me and actually send me to the top when I cut my finger off?
Great. Great.
Not that that would happen.
Well, thank you all very much. I'm happy to chat afterwards. Feel free to contact me.